the conclusion with. But more importantly, there were many men in the study that died. 40 of their wives contracted syphilis, and then 19 children were born with congenital syphilis. And so this is, I mean, less than 100 years ago. And so it's an example of why research ethics and research review, so like IRB boards, are really important to make sure that we're protecting the patients that we do clinical trials on. So as we went through history and had different episodes where patients weren't protected, there are lots of different codes and guidelines that were developed. So the Nuremberg Code was developed back in 1949, which developed after World War II, and it had lots of different principles in it. Declaration of Helsinki came about in 1964 that the World Medical Association developed. The Belmont Report was developed in 1969. And so if you ever do city training, this is covered pretty extensively in there. And it was created by the National Commission for the Protection of Human Subjects of Biomedical and Behavioral Research. The CIAMS, or WHO International Guidelines, were initially developed in 1993, and it goes through an extensive guideline for different groups, especially women, children, any groups that are at increased risk of being taken advantage of in research. And in the ICH GCP International Conference on Harmonization and Good Clinical Practice is a unified standard for the European Union, Japan, and the US. So let's go over the Belmont Report a little bit, because that's something that is pretty commonly taught and something that people will have to review if you ever do go through training for research. So there's 3 guiding principles in this report. The first is respect for persons, the next is beneficence, and the third is justice. And this remains the basis for the United States Department of Health and Human Services Human Subject Protection Regulations. So the first is respect for persons, which does a few different things. It protects the autonomy of all people, and in doing this allows for informed consent. And it also says that researchers must be truthful and conduct no deception. And so where the respect comes from is really you're telling people what they're involved in, you're giving them all the information involved, and you're allowing them to make the decision of whether or not they want to participate in the research. Beneficence is the philosophy of do no harm, which is very common in medicine. And you really are looking at weighing both maximizing the benefits for the research project, so getting the most knowledge for treatment, conditions, whatever your end goal question is, while still minimizing risk to the research subjects. And then finally, there's justice. And this is ensuring reasonable, non-exploitative, and well-considered populations, and making sure that they're administered fairly and equally, and that there's a fair distribution of costs and benefits to potential research participants. And so this talks about making sure that all of the populations are treated fairly regardless of what their underlying condition is, what their underlying population is, such as if they're women, if they're children, if they're at a higher risk due to some nature, and that the treatments are administered fairly. So what does this boil down to? There's really 7 principles of creating an ethical framework. And so we'll go through those and talk through a few different examples. And then this will kind of give us an overview of the things you want to consider when you're creating a project. So the first is that you have a valuable scientific question. So you want to say, will this question generate new knowledge? And is it a socially, clinically, or scientifically useful question? So one of the examples I came across was this man was in his clinic, and he had a physician friend run down, and the physician was like, oh, guess what? I just transplanted an appendix. And the guy was like, why did you do that? It's neat, and it's neat that you have this knowledge now, but will it benefit the patient? Is there any knowledge that is gained from it? And so really, if it's not a valid question, you should just cut it off there, even if the rest of the study is designed well. And so you can also look at social value with this. So how will the research improve the health of various populations? So this is both participants in the research, the community in which the research is conducted, and then the world. And so examples of research that may not have value are studies that are non-generalizable, studies that are just kind of me too, this is what happens, and research that cannot be disseminated. The second component is having a valid scientific methodology. So you want to design it in a methodologically rigorous manner. And this also needs to be practically feasible. And so if you have a good idea set up and you say, these are all the components that would make it, methodologically the same, is that actually practical for you to do? If it's not, then it wouldn't be falling under this question. You have to produce both reliable and valid data that you're able to interpret. So some examples of invalid research are either underpowered studies where they do the research and they don't have a significant enough population that they're actually able to come to result or conclusion, studies with biased endpoints, instruments, or statistical tests, and also studies that cannot enroll sufficient subjects. The third principle is fair subject selection. And so this talks about inclusion criteria and targeted populations, and you should really decide what populations you want to include based on the objectives of the study, not by vulnerability of the population and not by privilege. And so kind of jumping down to the bottom of the slide, you shouldn't just let rich or powerful persons, is how they described it, only for promising studies. So a lot of times if you have let's say someone was like, oh, I have a cure for cancer and you can enroll in this study and it'll cost this much money. You're going to get a very limited number of population. It's only going to be those people who are actually able to participate and have money to participate rather than actually benefiting everyone. And you also want to make sure that you're not targeting people that are vulnerable as well. And so going back to the example of the Tuskegee syphilis study, that's a good example. If you look at some studies that use like prisoners only for their population, that's another example. And so once this is done and you've actually selected your subjects, you can then look at lowering the risk and enhancing generalizability. So obviously, in order to make it generalizable, you want to make sure that your study population is broad. And so that's where, when you read through a paper, you look at the distribution of men, women, they came from this race, this area of the population. Is this something that is actually applicable to my clinical practice? So that is the goal, but that's not the primary goal. You should not just select convenient groups, and you can't exclude groups without scientific reason. However, it is an appropriate reason to exclude them if there's a higher risk. So say you're testing a drug and one of the known side effects of this drug is kidney injury, or that it increases creatinine by a certain percentage from some early studies, then excluding patients with grade 3 or 4 kidney disease would be an appropriate group to exclude, because that these patients would be affected in a very negative manner by that research. The fourth principle is favorable risk-benefit analysis. And so there's really 4 different components of this. The first, you want to identify the risks, assess them, and then make sure that these are minimized. So there are different variations of risk that can affect a patient. So these can be physical. If you're giving a drug, it can have side effects to it. Psychological, there's a lot of mood, anxiety, depression that can go through and surround being in a research project. Social, and also economic. So sometimes patients have to spend money to get to the site where the research is done. There's interesting discussions on whether, let's say this project is happening in a clinic that's in a dangerous area of town. Is the patient traveling to that clinic through that area of town? Is that part of the risk of the study? So that's something to evaluate. You want to look at the likelihood and magnitude of harm, and then also evaluate ways to limit the risk. The second is potential benefits to individual participants and making sure that these are enhanced. So the same risks that they have are also benefits. You can have physical benefits. So if you're trialing a medication, some patients can have benefits and positive outcomes from a medication. Psychological benefits, a lot of patients who enroll in research studies like the fact that they are both getting a potential treatment, and that there's also this component that they could benefit other patients with the disease process. social and economic benefits. And something to consider is that you only want to think about benefits from the research interventions, not from the added health services that they're getting or payments necessary to reach the end goals. So anything involved as an extra incentive or additional health services that they're getting as part of this research does not actually count as a benefit to the patient, only the benefits that they're getting from the research intervention. The third component of this is that if the potential benefits to the individual outweigh the risk, then you can proceed. And if the risks to the individual outweigh the benefit, then you want to evaluate the risk against social benefit of knowledge gained. And so all of this is really a pendulum and weighing risks and benefits, which is why there's lots of discussion on different projects and whether or not they are valid. The fifth is independent review. And so this is commonly by IRB boards. And so investigators that are designing the projects do have multiple legitimate interests. They want to obtain more knowledge. They may be invested in knowing whether or not a treatment that they developed or want to trial works. And they also may be interested in having better patient outcomes from a treatment. And so having an independent review takes out those interests that the investigator has and makes sure that is actually valid for the patient. And then also assures society that it won't be benefiting from abuse of the research subject. Sixth is informed consent. And so this ensures that an individual decides whether they first enroll in research and secondarily, whether research fits with their own values, interests, and goals. And so this is something that we come across a fair amount in at least a small scale. So consenting patients for a lumbar puncture or a blood transfusion and talking through the risks and benefits of this and alternatives. So there's lots of questions that come up, what if they can't consent? Whether you have children, which is what we'll come across a lot, if there's some sort of illness process going on. So say a patient comes in with a traumatic brain injury and they're not at the capacity to consent, are they still able to be involved in research? And also patients who are mentally impaired. And so you must really ensure that research fits with their interests. And a lot of times thinking about children, at a certain point, even if the parent is the one ultimately giving consent, they'll also have the child sign the consent form, knowing that they are involved in doing this. So what is informed consent? You need 4 different components for it. You need competence of the subject. They're able to make informed decisions. You need adequate disclosure of information to the subject, understanding or comprehension by the subject, and then voluntariness of the decision, which seems pretty straightforward. But as we've seen, there are lots of trials that have been done that did not include all these. And so this is why those have been laid out. And so federal regulations actually require that there are 8 elements that have to be included in the informed consent form. And this is what those are: the purpose and duration of participation, any risks of being involved, any alternatives and benefits that the patient can get, confidentiality of the records and how those will be kept confidential, any compensation that would occur if the patient was injured as being part of this trial, the person to contact for answers to questions, and also informing them that it is voluntary and they do have a right to withdraw from the trial at any time. And then last is respect for enrolled subjects. So this kind of goes back to that respect portion from the Belmont report. So a lot of times we think of informed consent being the aspect of respect because you're allowing them to say, I want to participate in this. I know the risks and benefit, and I'm going to do so anyways. But it doesn't just stop at informed consent. You also need to monitor the welfare of subjects, protect their confidentiality, permit them to withdraw from the study if they want to, provide any new information throughout the duration of the study. So say during the study, it was a large scale and you learned that this drug has a possible benefit or a possible harm, then that's something that you should tell them, and also inform subjects of what was learned from the research. So that is kind of the end of that portion of the presentation. Does anyone have any comments or questions? Yes.
What if the kid is like, if the kids are in the foster system, sometimes is the foster parent consent?
Yeah, so that's a really good question. So the question is, if the child is in the foster system, who provides consent? And so the cases that I've seen of this have a lot of times been in kids who were really little, like in the NICU or shortly thereafter. And really what it goes down to is looking at the DSS or CPS guidelines and looking where they have the consent laid out. So if a kid has been removed from their home and put into foster care, there can be a variety of ways that's done, because sometimes parents still have parental rights to give consent. Sometimes they don't. And then the state would be the one providing consent. That will get into a much touchier and more difficult conversation if it is a state providing consent, because like one of the examples I've seen was in the NICU when they were warded, they've been in the foster care already. And the question was whether or not they're going to be circumcised. And so that's a long-term practice that's going to affect the kid for the rest of their life. And you really have to think, is this something that will benefit them ultimately? And those questions can get really hard. I don't know if that really answers that. All right. So the last part of this, I'm going to talk about the procalcitonin project that I'm doing. And this is really kind of giving you guys an overview of the project, how it's set up, and asking for your help in getting data collection. And so this is something that I've been working on with ASP and with the hem-onc attendings. And we're looking at procalcitonin in two different populations, fever and neutropenia, and in sickle cell. And so in sickle cell, there's been a lot of studies that have actually shown that procalcitonin is useful, because if you look at other inflammatory markers like CRP, they will be elevated in sickle cell because of the chronic illness and the sickle cell in general. So you can test a healthy or baseline patient with sickle cell and they can still have an elevated CRP, whereas that's not the case with procalcitonin. So it can be really helpful for limiting extending antibiotics in them. So as you'll see in the little flow chart that we came up with, the goal for sickle cell is really to limit extended antibiotics in patients that don't have signs of bacterial infections, and then also obtaining more data. The second population is the febrile neutropenic patients that come in. So these are our ONC patients, and there is not a lot of data out there with how procalcitonin is impacted in fever and neutropenia patients. And so this part of the study is just getting procalcitonins to look at, is this a viable marker for us to use? Because as you've seen, patients that come in with AML and their counts get low and they're here for a month and they have fevers for 2 weeks straight, do they need to be on antibiotics for that whole time? Do we think they have something? We're seeing if procalcitonin is a useful decision-making factor. So basic definitions: fever is a temp of 101 or 100.4 or higher within 4 hours. And neutropenia can vary depending on who you talk to, but is usually less than 500 to 750. So procalcitonin is useful in determining bacterial versus viral infections, determining the length of antibiotic treatment, and monitoring the response to antibiotic treatment. It is not affected by neutropenia, immunosuppressive states, steroids. However, you want to keep in mind that some contained infections, such as abscesses or osteo, you might have that infection and it won't actually make the procalcitonin rise reliably. There are some things that can cause false elevations in procal. So newborns, the stress associated with birth, they'll have a procal elevation for at least 72 hours. Some attendings in the NICU will say it's not really reliable for up to 1 to 2 weeks. Any sort of massive stress from trauma, surgery, burns, agents that stimulate cytokines, malaria or other fungal infections, end-stage renal disease, graft-versus-host disease, vasculitis, some sorts of cancers, pancreatitis, and Kawasaki disease. And so I created 2 different flow sheets to look and really obtain this data. So in sickle cell, and I'll just kind of go over this, and then if you have any questions about how to do this, please feel free to ask. These are also up in the 5th floor rounding room too. So on the right side, it just has all the info about fever, neutropenia, procalcitonin that we just discussed. So if a sickle cell patient comes in and has a fever, when you initially get blood cultures, you want to order procalcitonin, and then you'll start antibiotics like you always do. Because procalcitonin levels might be low during the initial onset of bacterial infection, you'll repeat it in 12 to 24 hours, but this can really be whenever your next blood draw is. So say a patient comes in one day, you're going to get morning labs the next morning, your procal can be with your morning labs the next morning. If the procalcitonin is less than 5 twice, you don't need to repeat it. So if that initial procal was less than 0.5 and your repeat procal is less than 0.5, then you're done. If it's greater than 0.5, then we'll repeat it every 48 hours until it comes down to less than 0.5 times 2, and then you can stop trending it. This is something that we had a lot of discussion about how often to repeat and how long to trend it. And more so in the fever and neutropenia patients, these are the guidelines which we'll see that it's beneficial to get data on procal. There are some instances where you may say, this isn't giving us any useful information and we're just going to stop trending it. And so for sickle cell patients, since we're actually trying to utilize it to discontinue antibiotics, you can discontinue antibiotics when a blood culture is negative times 48 hours. You don't have any focus or known bacterial source of infection, which are guidelines that we normally use anyways. And then also when the procal is less than 0.5 times 2. And this really helps weed out those patients who may come in and have a fever associated with vaso-occlusive crisis, no bacterial infection, their blood cultures are negative, they don't have any known source, it's just pain related, but they kind of linger on antibiotics for 4 or 5 days because they're still having fevers. These are those guidelines to help get those patients off an extended course of antibiotics. So these patients can still be febrile at that time. So then for the neutropenic patients, it starts off the same. When you initially get blood cultures, you'll get a procalcitonin and then start antibiotics, or if they're already on antibiotics, consider escalating them and then repeating them in 12 to 24 hours. If it's less than 0.5 times 2, you don't need to repeat. If it's greater than 0.5, repeat every 48 hours. And then you can stop trending it once it's less than 0.5 times 2. And then the end goal is that once they're afebrile, greater than 24 hours, to repeat the procal once more. And then this is really going to be a big discussion between hem-onc attendings, ASP, all the clinical staff, whether or not they want to discontinue antibiotics. But the goal for this is not to say we can use it to discontinue antibiotics, because there isn't good data on that. It's really just to see, will those patients who have positive blood cultures end up with elevated procalcitonins? So can we use that in the future? And I will send out these flowcharts to people so that you have them to look over. The big things are when they first get blood cultures with a fever to get a procal, and then one the next day. Any questions? All right. Thanks, everyone. I don't know how to get back to Zoom.